Good morning, everyone. It's right at 11 a.m., so I'm going to go ahead and get us started. Howdy, and welcome to San Antonio, Texas, and Anesthesiology 2025. We have an engaging set of speakers this morning who are all very innovative and prolific speakers, very well established in the field of thoracic anesthesia, who will be taking us this morning through the ABCs of thoracic anesthesia: airway, the linchpin, breathing, and then circulation. We will first have A for airway and A for Dr. Alessia Pedotto, who is a professor at Memorial Sloan Kettering Cancer Center and serves as the Fellowship Director for the Thoracic Anesthesia Fellowship. Without further ado.
Good morning, and thank you for joining us. It was a chore finding this room, but you did it. So, airway. Let's see. Okay, here is my 9 minutes going. How do you advance the slides? All right. Okay. So, what I want to do in the next 9-10 minutes is to lead you through what is the definition for difficult airway. We are going to present some case scenario, and I'm going to give you some options and some management tips on what to use for lung isolation in case of a difficult airway, and hopefully I'm going to leave you with some very clinical pearls, very practical clinical pearls that you can take home. I have nothing financial to disclose. I will be mentioning airway devices since this is an airway talk, but again, I don't have any relationship with any of the manufacturer, and hopefully I'm going to leave you with an unbiased message coming out of this room at the end of this talk. So this is the case I'm going to start with. He's a 76-year-old man with adenocarcinoma of the right lung who came for a minimally invasive segmentectomy or lobectomy that was to be decided. His history was significant because of tongue cancer. He had surgery, he had a hemiglossectomy, and he had head and neck radiation afterwards. He also had a cervical spine fusion for disc herniation. In terms of his medication, nothing really outstanding. His labs were normal, and as expected, his physical exam showed some limited range of motion. He had limited mouth opening, and he was stiff overall. With this said, my resident and I had a plan. These were the red flags in his history, and we decided for his intubation to put him in sniffing at the best we could do, pre-oxygenate, and then do a combination with a video laryngoscope and put in the double lumen tube with the aid of the fiber optic. And it went really very well. This is the anesthesia record. It was fairly straightforward, not the fastest, but we succeeded. And this is the image. As you can see, he has some laryngeal edema with the epiglottics and the false vocal cords, probably related to the head and neck radiation. And on the right side is the image of the combination of the video laryngoscope and the fiber optic to put the double lumen tube in. However, when we went to check the position of the tube, this is the right main stem. We found this. And the surgeon said, I need to biopsy. So as you know, you cannot do a biopsy through the double lumen tube. So that means that we had to take that double lumen tube out and put something else to allow the bronchoscopy. So when you have someone with difficult airway, you have to answer 5 questions, which are basic questions, which are the same as the ASA algorithm. So can you mass ventilate the patient? Can you put a supraglottic device as a rescue? Can you intubate? In case you need to do a trach, is there a path for you to do that? And then, since we are doing thoracic surgery, can I isolate the lung? And as you can see, the isolation is at the very bottom of all these questions. So algorithm, you all know, we don't need to go through it. This paper came out in 2024, and similarly to the ASA guidelines, it kind of leads you through how to approach a difficult airway if you have to do lung isolation. And so the first question is, do I need to isolate the lung? How do I do it? Do I do it with a double lumen tube, or can I use something else? Can I go through the mouth, or do I need to use a different route? And then it takes you down to the unanticipated and the anticipated difficult airway. So I highly recommend to read this paper. That's the QR code that takes you to the PDF. And this is another very nice paper, very simple, that leads you through all the options that you have available. But the meat of this is that when you are dealing with someone who's difficult, you need to figure out what are the indications for lung isolation, where are the problems. So is this an upper airway abnormality or a lower airway? What equipment do you have at your institution? And at the bottom line, how comfortable you feel picking something versus something else and making it work during the case. So Again, the first component is to secure the airway, and then you decide how you want to isolate the lung. So you have many options. You have double lumen tubes. This is what we usually use. You have bronchial blockers through a single lumen, and you could do endobronchial intubation. Now, to start with the endobronchial intubation, a single lumen tube is not meant to be in a main stem, so you can use it as an emergency, but it should not be your elective way of isolating the lung. And this is the reason. So I did a little bit of arts and crafts. And so on the left, you can see the cuff of the single lumen tube is a big cuff. So it's going to herniate above carina. It may obstruct the lung that you need to ventilate. The tip of the tube is also long. It's like 3 centimeters compared to ½ centimeter from a double lumen tube. So that is going to wedge into your secondary carina. And so if you live outside the United States, there are commercially available endobronchial tubes. So if you want to do an endobronchial intubation, you should use something that was built for that. Now, usually we commonly use either double lumen tubes or bronchial blockers. And we usually favor double lumen tubes because you can choose the size, the side. It's easier to do sequential lung isolation. You can suction very well. You can do CPAP. All things that you can do with a blocker, but it's less, easy. Blockers have kind of like a bad rap because they tend to move, and they always go on the surgical side. So if you're doing anatomical resection, you really to be mindful of the fact that they can be stapled into the specimen. However, they're your friends if you have someone with difficult airway. And there are several options commercially available. You probably have some or other at your institution. Now, if you're really, really strong about using a double lumen tube, you can use airway exchangers or introducers to facilitate the process. However, don't be fooled by the fact that this gives you a 100% guarantee that you can go from a single lumen tube to a double lumen tube, because you may not. And also, these are very stiff pieces of equipment that can cause damage. And so be aware of the complication. This is a cute case report that came out in Anesthesiology News a couple of years ago, and it describes the case of a difficult intubation who ended up with a right pneumothorax related to airway damage from the tube exchanger. And this is a more scientific presentation of the same problem. They took 1,200 patients, and as you can see, the highest amount of airway complication when you use a tube exchanger is when you go from single lumen to double lumen tube. And one trick that you can use is to use 2 tube exchanger. You put 1 per lumen, and that is going to increase the success rate of the double lumen tube going through the vocal cords. This is something that happened to me. I was using a double tube exchanger, and as you can see, the tip bent, and now I'm trying to pull out the tube exchanger, and it's caught with the bronchial side of the double lumen tube. So I had to pull the tube out, and I was hoping that I wouldn't have to extubate to take the tube exchanger out. If you don't like blockers because you think that the lung collapse is not ideal, you are mistaken. There are like a lot of publications that demonstrate similar quality of lung collapse. This is one of the latest. And so it's something that, again, it's a myth. And in the majority of cases, the discomfort of using a technique versus the other is based on the non-familiarity about the airway anatomy with the fiber optic. And this is a very good website. It's free, coming from the University of Toronto, where it's very interactive. You can learn how to use the fiber optic scope and learn the anatomy. Special case scenarios. You cannot do difficult airway lung isolation without mentioning tracheostomy. So if you have someone with a tracheostomy, you need to decide if the tracheostomy is old versus young. So a young tracheostomy is something that is less than 7 days, and the recommendation is to leave the tracheostomy cannula and to use a blocker around it, outside or inside the device. If it's old, more than 7 days, at that point you have more leeway, so you can still leave the trach in place and put a blocker inside or outside. You can take the trach out and put armor tube in, or worst case scenario, you can do a main stem intubation. In the United States, we don't have those devices, but if you live outside the States, you have double lumen tubes that are built to fit the stoma of a trach. These are all the blockers that you have available. I personally like embolectomy catheters because they're very soft and the tip is very short, and so it accommodates very well into a main stem if you have a trach. And this is an example on how it looks like. You put an armor tube in, you put the blocker outside, we sutured it, and this is the quality of lung collapse. On the left side, right side, you have the surgical field, the lung is perfectly collapsed. And this is what it looks like on the left when you do the first bronch. This was a left main stem embolectomy catheter. As you can see, again, the distance between carina and the tip of the tube is very short, and so you have to be cognizant that the tube can go main stem. Pig bronchus, you can do double lumen tubes, you can do bronchial blockers. I personally like double lumen tubes, but they have a ton of case reports about putting double blockers inside the airway. Again, be aware that the blockers can get stapled in and they can move. And this is the original paper that came from our institution on the use of two blockers to isolate the right side as an elective technique. That was before the commercially available blockers that are, 2-in-1. The two blockers is something that can come handy in case the surgeon changes their mind. This was a case that I did. It was a chest wall resection. We started with single lumen tube. We were on the side and open, and the surgeon decides that now he wants lung isolation. And so I didn't want to extubate, obviously. And so I put two blockers, one inside. Actually, both of them were inside the single lumen tube, but because there's no commercially available connector, I put the embolectomy catheter through the fiber optic port. And as you can see, there's a lot of bone wax around it so that you don't have a leak and the blocker comes out. And you just have to hope that you don't have to go back in there and check the position, because then all that bone wax has to come out. And then finally, again, you have a lot of options how you can use these blockers. You can put them even in adults outside the endotracheal tube, and if you do that, the blocker goes in first, and then the tube seals the blocker in place. You can put them in through the nose if you're doing nasal intubation, or in Europe, they do cases like the non-intubated with supraglottic airway, and so they put blockers through the supraglottic device. So going back to my case, what did we do to reintubate this guy? Well, we had a supraglottic device because we were doing the bronch, so we took two tube exchangers, and then we put back the double lumen tube, and this is what it looked like. The airway was much more edematous after they were done with the bronch, and this is the fiber optic guidance of exchanger number 1, which is too short, so you need exchanger number 2, which is long enough to put the double lumen tube in. And this is the double lumen tube that is going in with the aid of the video laryngoscope, and this is the double lumen tube in place. And so when, my take-home message for this is that if you have anybody who's difficult, you have to identify where the difficulty is, either upper airway, so that's your physical exam, or lower airway, this is your CT scan or imaging. You really need to have all the tools that you need available in the room. Maybe not opening all of them, but have them handy. And I think that help should be included as all the tools, like the surgeon, the nurses who know how to use anything that you may need. And you need to be creative and combine several techniques and be cognizant that anything that you use can cause complications, and so be aware of not forcing anything. And this book is coming out. Vanda is one of the authors, she's one of the speakers, so a lot of these cases about difficult airway are gonna be in that book, so stay tuned. And thank you for your attention.
Thank you so much, Dr. Pedotto, and thank you so much for transitioning us to Dr. Popescu, who is also obviously a master of the airway, but will actually be talking to us today about breathing, oxygen and one-lung ventilation. How much is enough? How much is too much? Dr. Popescu is a professor at Yale, and she's also their director of thoracic and vascular anesthesia. Without further ado.
Thank you very much for being here. Switching a little bit gears, FiO2 in general has received very little attention in the area of protecting lung ventilation, and my colleague Marcelo is going to talk more about that, but I want to focus a little bit on this. Which one?
Mouse.
Okay. So, objectives for today, discuss a little, very tiny little bit on the physiology and pathophysiology of one lung ventilation, and more specifically, evaluate the impact of delivering high FiO2 on overall outcomes after thoracic surgery, and then hopefully at the very end develop a rational strategy of managing FiO2 in thoracic surgery. So I'd like to start with this. I was a first-year resident 1 week into my residency, and I thought I'd be really smart by asking my attending to talk to me about absorption atelectasis, and he gave me the following answer: well, if oxygen is so good, Why do you think God created air with just 21% oxygen? So I'm just going to let you ponder on that thought, and hopefully by the end of this talk, we can be a little bit more rational about it. So in 2015, this Cochrane review looked at the impact of giving patients undergoing general anesthesia, this is not thoracic anesthesia, just your general cases, whether intubated with endotracheal tube or LMA, giving low FiO2 defined as below 40% or high FiO2 defined as more than 60%. They looked at 21 randomized controlled trials, almost 8,000 patients. What they identified is basically that a high FiO2, they could not associate it with increase in all-cause mortality, respiratory insufficiency, serious adverse events. But at the same time, nor were they able to say that a high FiO2 is correlated with decreased surgical site infections. So their conclusion was that there is insufficient evidence to support high FiO2, meaning more than 60%, in general anesthesia. However, just 1 year later, as we all know, World Health Organization came with this particular recommendation suggesting that adult patients, this was a very strong recommendation, adult patients undergoing general anesthesia with endotracheal intubation should receive FiO2s over 80%, and in postoperative, 4 to 6 hours should maintain this additional FiO2s. There was a lot of uproar when this thing came out, mainly because they did their meta-analysis based on including 3 studies that were fraudulent. And Paul Miles published data on that. So in 2018, they came back and they said, well, we'll just give a moderate recommendations for that. In 2019, once again, looking at this issue of FiO2, this was meta-analysis, 10 randomized controlled trials, and again, divided high versus low. High was this time considered more than 80%, low less than 50%. And they identified that actually in the high FiO2 group, you have lower postoperative PaO2s. And that was their primary outcome. And you have higher AA difference and more severe atelectasis. Once again, cautioning us that use of high FiO2 in patients susceptible for post-op pulmonary complications, we should be really cautious about that. How about FiO2 in lung surgery, one lung ventilation? Well, using 100% FiO2 before deflating the lung actually could be used towards our advantage because it produces absorption atelectasis, so they're, let's call it, desirable. However, in the lung that we ventilate, and we ventilate with this protective lung ventilations, which require lower tidal volumes. And most of us don't go through the exercise of identifying optimal PEEP, and many times have lower PEEP. We can potentially promote more atelectasis, which could be kind of problematic. So looking at what is the pathophysiology of one lung ventilation, well, on the ventilated lung, we have a mechanotrauma from the actual ventilation, while on the non-ventilated lung, obviously, we have surgical trauma. But on both lungs, in particular when we use high FiO2, we have this atelectotrauma. And that, in general, generates biotrauma. Biotrauma manifested as all these types of inflammation, oxidation, nitrogenation that functions as a sort of vicious circle, further impacts the lung, and then you get more and more into this vicious circle. And for all practical purposes, let's focus on atelectotrauma and oxidative stress. In addition to atelectasis, what happens with one lung ventilation? Well, if one could ask, where is the oxygen coming from for the cells in the lungs? Well, 20% is coming from the bronchial circulation, but 80% of it is coming from the oxygen-rich environment. But in the non-ventilated lung, that oxygen-rich environment actually decreases. In this particular experiment done on dogs by Paul Heard in the Yale Heard Labs, what they identified that the delivery of oxygen in the non-ventilated lung at the end of hypoxic pulmonary vasoconstriction was like 33.7, and it went to half just before we re-expanded the lung. So clearly there is a decrease of oxygen delivery to the cells. So what is happening? Could this lung potentially be ischemic, and could it shift from an aerobic to an anaerobic metabolism? And then comes the final kick. You're opening up the lung, and so the question is, are you generating some type of ischemia reperfusion injury? And there is data currently in lab form to show that that is most likely what is happening, and the reperfusion time, reopening and re-expansion is the most critical time. This study looked at 220 patients that were undergoing thoracic surgery. They had cancer and non-cancer situations, and they looked at levels of malondialdehyde, which is a surrogate of oxidative stress, in relation to one lung ventilation. You see here depicted that at the time of re-expansion, the patients that underwent one lung ventilation had a dramatic increase of their MDA levels. So lung re-expansion was significantly associated with oxidative stress, and the amount of free radicals was in direct correlation with the duration of one lung ventilations. And they also identified that patients with cancer that are known to be in high inflammatory states have a higher production of oxidant-free radicals and a lower ability for them to actually buffer this state. So clearly delineating that there is a problem, duration of one lung ventilation is a problem. Just recently published, this is a study from MGH. They looked at almost 3,000 patients, a retrospective study, and they said, look, let's just look at patients undergoing thoracic surgery who don't have problems with hypoxia intra-op, because a lot of practitioners say, well, I gave 100% because the patient was hypoxic. So they took all the patients that had average intraoperative saturations above 95%, and they wanted to see what's the impact of FiO2 on postoperative oxygenation. Just to describe this situation, 75% of practitioners use above 80% FiO2, even though the saturation is more than 95%, and just 25% of practitioners use FiO2s that are less. So what were the results? So they looked at this impaired postoperative oxygenation, which was defined as postoperative saturations below 90% or a PF ratio below 300, which had to occur twice in the span of the first 24 hours, or need for mechanical ventilation with FiO2s above 50% and high-flow nasal cannula. As you can see, in the high FiO2 group, almost 75% of the patients had this impaired postoperative oxygenation. When they did a propensity score weight analysis and they did propensity matching for over 75 variables, what they found out was that the high intraoperative FiO2 was associated with an 84% increased risk of developing impaired postoperative oxygenation. So the high FiO2ers certainly did not have a better oxygenation postoperatively. We did a study looking at similar issues, and we used the MPOC database, which for all of you that don't know, MPOC collects data from EPIC, and we matched MPOC together with STS, so we were able to have the results of postoperative from the STS database. Included 2,733 patients from 4 centers, Yale included. What we had is 60% of the practitioner delivered discretionary high FiO2. We defined that as FiO2s above 80% in the setting that the saturation is 98%. 141 patients, or almost 5% had a composite outcome of postoperative pulmonary complications. And we define that as pneumonia, atelectasis, ARDS, respiratory failure, reintubation, or postoperative ventilation with more than 48 hours. If you were in the high FiO2 group, you had, in univariate analysis, a higher chance of developing postoperative complications. But when we put it in the multivariable analysis, we found out that really it wasn't the FiO2, but more the duration of one lung ventilation. And time-weighted average of the FiO2 was not associated with pulmonary complications. I'd say rather disappointing, but these were the results. However, we did a post-hoc analysis, and we looked at the FiO2 10 minutes before re-expansion and at re-expansion. The mean FiO2 at re-expansion that the practitioners used was 82.7%. And here we identified that actually average re-expansion FiO2 utilized was directly associated with postoperative complications. And as you can see here, the higher your FiO2, the higher your predicted probability of postoperative complications. That's so much so that for every 10% increase in FiO2 at re-expansion, there is a 14% greater odds of developing postoperative pulmonary complication. Once again, the duration of single lung ventilation was associated with post-op pulmonary complications. So I hope I convinced you that intraoperative FiO2 is at the very minimum associated with absorption atelectasis, whether in general or thoracic anesthesia. The duration of one lung ventilation and re-expansion seem to be the critical events that determine postoperative pulmonary complication incidence. So hopefully you can consider utilizing a lower FiO2 if your saturation of oxygen during one lung ventilation is adequate. But more importantly, if you choose to use 100% or 80% during one lung ventilation, I think one of the most important times is re-expansion to two lungs. And that should be okay, that you should try to decrease your FiO2 to the lowest possible that the actual patient will be able to tolerate. And with that, I'd like to thank you.
Thank you so much, Dr. Popescu. We do have two additional speakers. I will remind you that you can submit questions through the app, as well as at the end of our four speakers, we'll certainly invite questions at the microphone. As you know, breathing is the linchpin of thoracic anesthesia, so we've decided to devote a second breathing talk. And so I'm inviting Dr. Gama de Abreu to discuss with us what is the role of mechanical power and energy on postoperative pulmonary complications. Dr. Gama de Abreu joins us from Cleveland Clinic, where he's a professor of outcomes research of the Outcomes Research Consortium, as well as a professor of critical care. Thank you.
Thanks so much for the introduction. Thanks for having me. I have the disclosure that I have worked with those companies, but so this will not have any impact on my talk. So this is the agenda that we have for today. So I'll talk a little bit about ventilator-induced lung injury, energy and power calculations, show some evidence from experimental point of view, clinical evidence as well, and then come to the take-home messages. Ventilator-induced lung injury has been developing over the years. And I think that one of the first descriptions that we had was in 1973, so with the concept of barotrauma. So it developed further to the concept of volutrauma, and then 1997, atelic trauma, so which was mentioned before. So, and we are moving towards the direction of ergotrauma that we saw also before. And there are many variables in the mechanical ventilation settings that might lead to ventilator-induced lung injury. And you see some of them here: tidal volumes, plateau pressures, driving pressure, PEEP, respiratory rate, and flow. So all of them leading to VD. The problem is that, so they are interrelated. Sometimes you try to change only one of those variables and you are affecting also others. And you see many publications showing tidal volumes have an effect, plateau has an effect. so driving pressure, and so on and so forth. So it was in the year 2010 that this gentleman here, Professor Gutmann from Freiburg in Germany, he proposed the concept of transfer of energy from the mechanical ventilator to the lungs. And this is the original publication, is in German. I don't expect that you might be able to understand that, but maybe the title is worth translating. So, and he already talked about this concept. Again, so this was published in 2010. But it was not this gentleman, but Professor Luciano Gattinoni, who passed away last year, that proposed a very formal concept of the transfer of energy from the mechanical ventilator to the lungs, and this is the original publication from 2016. Basically, what he did was, and this is a little bit of math here, using the equation of motion. So you have here so the representation of pressure, and pressure is proportional to the elastance, is proportional to the resistance, and also PEEP. So we can transform this into work or energy. So if you multiply the pressure with the difference in volume, and we get energy from that. And if you divide by the time, so then we will get mechanical power. So basically, this is what is behind. So you have an equation of motion and you have time. And there are many ways to calculate mechanical power. It depends on the mode of ventilation. And you see here a table. And so it's highlighted here the first equation that was proposed by Professor Luciano Gattinoni. And you see here that you have different elements related to volume, to a static component, elastic component, a resistive component, and of course the rate. I will not go through all those equations, of course, just for you to know. So there are some simple forms and some more complicated. But there's another concept that is coming up, and it's very related to the previous talk, which is the concept of chemical power, not mechanical power. So when we are giving ventilatory support, maybe so pressure, flow, and so on and so forth, overweights. So the component of oxygen, and oxygen might also be injurious. So when we are talking about respiratory support without pressure, for example, high flow nasal cannula, maybe that, so the use of high oxygen concentrations may be more important. And there is a way to calculate, which is the contribution of the FiO2, so to the formation of those radicals, and that come from oxygen. So what you see here, so is this kind of production of those radicals, and you can transform this also into chemical power, which is expressed as the mechanical power in joules per minute. So there is a number of publications that have been appearing in the last times, and so about 1 week ago, so we had a total of almost 1,900 papers that had been published, so with the concepts of mechanical power, energy, and you see here those two gentlemen, so when they started contributing to that. So there was something related to that even before, which is the evidence that we have from the lab. And this is from the very first paper on this concept. And what you see here is a relationship between transpulmonary mechanical power and lung weight, which is edema. On the other side, you have the changes in PO2, FiO2. And it was identified that about a threshold of 12 joule per minute, you might have some kind of injury. But even if you ventilate in a protective way, and we saw this in our lab back in Germany. So, for example, we ventilate pigs with acute lung injury using low tidal volumes with a low PEEP table. You see that there is a kind of relationship between the mechanical power and also the absorption of this marker of lung inflammation, which means mechanical power might have an influence not as a threshold only, but over the whole range. But, so it's important to keep in mind this one study here that, so in my opinion, is quite important. It was conducted with rats. And what they tried to do is to have different variables influence the mechanical power. The most important one was the tidal volume. And what you see here are some pictures from microscopy of the lung of the rats that were ventilated with a low power and a low VT versus high power and a high VT. And you see here some infiltrates, so which means you had injury. So what happens if you have a high power and a low VT? According to the concept of mechanical power, so you have also injury, and this is exactly what we see here. So what do you expect if you were using a low power according to the concept, but a high VT? So, well, the concept of power would say, so you have almost no injury, and this is not what we're seeing. So it seems that every component counts. So not only the VT, not only the tidal volume, but other components as well. Let's see what we have in terms of clinical evidence so far. First, from the ICU, so we had this retrospective analysis of 2 data banks. It's a huge number of patients, something around 4,000. And what our group could see is that, so the mechanical power of 18 joule per minute or higher was associated with mortality, with a higher odds of patients dying. So this one here was conducted in patients with ARDS. They were not really able to see an association between mechanical power, so raw mechanical power with mortality, but when there was a correction for the size of the lung, so which is a concept of intensity, mechanical power divided by volume is intensity. So you see here that, so they could identify this kind of relationship. So going to the OR, and this is on two-lung ventilation. This is a very important study. So the number of patients that was included here is huge. These authors were able to identify 2 things. First, it seems that really after 12 joule per minute, you have a kind of increase in the odds of developing postoperative pulmonary complications. And so intraoperatively, if for any reason you increase the mechanical power, so it's not said how or why, but there is also an increase in the odds of developing these kind of complications. Our group has conducted a meta-analysis of 3 major trials with two-lung ventilation, so the ProVital trial, ProBeast trial, and the iProve. And what we saw here was also an association between mechanical power and so the chance of developing a postoperative pulmonary complication. So, and this was something that was more relevant beyond a threshold of 15 joule per minute. So we saw also here that there was an association, and possibly association that was even stronger with the chemical power. And the chemical power was also more important associated after 15 joule per minute. They were not additive, they were not, let's say, synergistic, but they were independently associated with the odds of developing this kind of complication. Coming out to one-lung ventilation, so what you see here is a very recent paper. Is a sub-analysis of the iProve one-lung ventilation trial. And the authors here, they could see also in those patients an association between mechanical power, not chemical power, with the odds of developing postoperative pulmonary complications, severe postoperative pulmonary complications. Well, we do have one sub-analysis of a study that it's not published yet, it's accepted for publication, so with more than 2,200 patients undergoing one-lung ventilation, and what we could see there was that there was an association between chemical power and the odds of developing postoperative pulmonary complication, but not mechanical power, so which was somewhat surprising. So the evidence that we have so far, let's put this clearly here. So what we have in terms of the pyramid of evidence is that we're still here. So we are talking about retrospective studies when we talked about clinical studies. We have to go all the way up so that we can make strong recommendations. But still, what I would like to let you know here and give as a take-home message is, so it seems that there is evidence to guide ventilation by mechanical power, but it is still weak. So we can talk also about energy, but this evidence is not robust right now. So avoiding increases in mechanical power as far as we can sounds reasonable. Sometimes it's easy to be accomplished, and the way that we might do that is to keep our tidal volumes always in the protective range, also driving pressure, to adjust the PEEP according to hypoxemia to avoid that, to avoid excess ventilation by limiting the respiratory rate, which is one of the major components that we have to influence the mechanical power during intraoperative procedures, and also to avoid excess oxygenation by limiting hyperoxia. So right now it's still debatable if mechanical power, energy are mechanisms or they are markers of ventilator-induced lung injury only. Thank you.
Thank you, Dr. Gama de Abreu. So moving through our ABCs, we're at C, not only for circulation, but for Dr. Cherikou, who is an associate professor at UT Southwestern. And we'll be talking to us this morning about when one lung ventilation affects the hemodynamics, what should I do? He's an associate professor, co-medical director of the CVICU, and also leads their ECMO program. Thank you.
Thank you. Thank you for the kind introduction. It's my pleasure to talk to you about the circulation of one lung ventilation and the things that affect circulation. I have no relevant financial disclosures. And so our objectives today are to see if we can predict hemodynamic compromise, to see if we can medically manage hemodynamic compromise under one lung ventilation, and then we'll briefly discuss extracorporeal support for management of hemodynamic compromise. So hemodynamic instability in thoracic surgery can happen because of very conventional reasons, dehydration, anemia, surgical factors, and so on. But it can also occur due to tumors invading the superior vena cava, the pulmonary arteries, or the cardiac chambers. And these are the portions which are relevant to the preoperative evaluation. A history and physical exam on these patients is always paramount, and it begins with looking for signs like plethora of the head and neck, which can indicate SVC syndrome, dyspnea on stridor, dizziness with flat positioning. Dizziness especially could be a sign of hemodynamic compromise to come, as well as an inability to lay flat. When I say an inability to lay flat, it's very important to determine what we call a rescue position in these patients. If you can't lay flat or you're having symptoms while laying flat, how flat can you actually lay? And that's important in the preoperative area to really adjust the angle of the head in these patients to figure out what is the rescue position if something happens. Preoperative imaging is very important to look for example, in this case, invasion of the pericardium by a mass, or also a SVC tumor or any other tumor that's affecting the great vessels. And it's this preoperative evaluation that allows us to identify which patients are high risk, which patients are intermediate risk, and which are low risk. And this table here is adapted from a really nice paper in the Canadian Journal of Anesthesia. But really, the high risk patients are those with severe postural symptoms, those with pericardial effusions or SVC syndrome. The intermediate risk patients are those with mild to moderate symptoms, and the low risk patients are those who are asymptomatic, those who don't have postural symptoms, those without radiographic evidence of significant compression of structures. And those are the patients who we're going to start with today in terms of evaluating their hemodynamics and how we manage these patients. The key to evaluating how we manage the hemodynamics of low-risk patients is really using either invasive or non-invasive, in most cases, measures of stroke volume. So, fluid management is obviously the big question in these patients, and restrictive fluid management is often used during one lung ventilation to prevent post-operative pulmonary edema. But fluids are often required to treat hemodynamic fluctuations. There are two ways of managing these fluids. One is by using static variables like CVP and pulmonary capillary wedge pressure, and others are by using dynamic variables. And dynamic variables could be stroke volume variation that you can achieve using the flow track or other non-invasive measures, or VTI obtained through echocardiography. While these dynamic measures are better markers of stroke volume in mechanically ventilated patients, they can be unreliable when the chest is open, unfortunately, in many of these patients, or when one lung is collapsed. So what does the evidence say? And that's really what I hope to do today, is to build you an evidence-based algorithm for the management of these hemodynamics. Can stroke volume variation obtained through pulse contour analysis guide fluid resuscitation and improve outcomes after one lung ventilation? So the first of the studies I'm going to review today is a randomized trial of patients undergoing video-assisted thoracic surgery. This is a study of 168 patients randomized between getting a stroke volume variation guided approach versus not. And in this study, the authors picked a stroke volume variation more than 13% as their threshold to activate a series of maneuvers, which results in really a colloid bolus of 4 ml per kilo, which is really, for many of you guys, a 250 ml bag of albumin or something similar into these patients. And then looking and then seeing if that improves the stroke volume variation, evaluating cardiac output non-invasively, and using some combination of dobutamine or norepinephrine to make sure that cardiac output is adequate. And then repeating this over every 5 minutes. So this is the first trial. What they found in this trial was that the patients who were randomized to receive this stroke volume variation guided resuscitation protocol, they ended up getting less fluid overall. They ended up getting less crystalloid overall, less colloid overall, and they ended up having much better outcomes. They had less pneumonia, less acute lung injury, and a lower hospital length of stay. So this was a very good trial. Another trial replicated these results. Again, this is a randomized trial of, again, patients undergoing video-assisted cardiac surgery. This is thoracic surgery, and this is 60 patients. And these authors, in this case, used a stroke volume variation of 11%. And again, they used the same conventional techniques, which is dobutamine and norepinephrine as needed. And they also found in this case that the patients who got stroke volume variation associated with resuscitation, these were the patients who had better PF ratios at the end of the case. A third trial, which is much more recent, by Punzo and colleagues in the Journal of Clinical Medicine, used a much lower pulse pressure variation threshold. You'll recall in the first two studies that they used 13% and 11%. This group of authors actually used a pulse pressure variation of 5.8%, and then they gave fluids based on that. And this was a negative trial. In this trial, the patients ended up getting more fluids overall in the group that got the stroke volume variation associated transfusion, and the PF ratio was actually higher in the group that got the stroke volume variation associated hemodynamic management. Moving from fluids to norepinephrine and vasopressin. Again, there's not a lot of good evidence for this, but in septic shock and cardiac surgery cohorts, vasopressin is superior in patients who have concomitant pulmonary hypertension. There's very limited data in thoracic surgery patients. There's actually a retracted paper, which we're not going to use up here, but this is a rodent study, a preclinical study, which actually shows that in mice undergoing one lung ventilation, if you give them norepinephrine versus vasopressin, the rats who got vasopressin actually have less of an increase in pulmonary arterial pressure, and they also have better perfusion to the lung that is being ventilated. There are case reports in humans undergoing one lung ventilation. In these patients, what you can see is that when you get norepinephrine versus vasopressin, there's a much significant increase in the systolic pressure compared to the PA pressure. In fact, what they found in these patients was that when norepinephrine is used, the PA pressure is about 7% less than the systemic pressure, but in the vasopressin group, the PA pressure is about 33% less than systemic pressure. Moving from inotropes to pulmonary vasodilators, which may be important in some portions of your patients. Does inhaled nitric oxide decrease pulmonary artery pressures in one lung ventilation patients? And there's a prospective observational study of VATS patients. This is 30 patients undergoing who got 40 parts per million of nitric oxide. And what they found was only in the patients who had pulmonary hypertension, only in the patients who had a mean pulmonary arterial pressure that was more than 24, what they found was there was a significant decrease in pulmonary artery pressures when these patients were prophylactically, at the beginning of the operative procedure, placed on nitric oxide. So based on all of these studies, which are kind of very difficult to go through, let me build an algorithm for you. If the patient is hypotensive, it makes sense to look at some sort of stroke volume measurement. If the stroke volume is low based on that kind of measurement, consider a fluid bolus. And then after that, it makes sense to look at least non-invasively at what cardiac output is. If the cardiac output is low, consider dobutamine and nitric oxide. Now, in patients in whose pulse pressure variation is less than 10, it makes sense to consider either norepinephrine or vasopressin, and this depends on whether or not they have concomitant pulmonary hypertension. To kind of really round out this, how do we optimize hemodynamics, I want to present to you a very new study, which is, does the choice of IV anesthetics affect hemodynamics in patients undergoing one lung ventilation? And we go to China, where in lung surgery in China, they simply do not use volatile anesthetics in many parts of China. They only use TIVA. So it allows them to really compare different approaches. So in this randomized trial of elderly patients, aged over 65, undergoing lobectomy and one lung ventilation, of course, it's 84 patients. They randomized these patients to receive TIVA with propofol versus remimazolam, which is a newer medication. And what they found, and you'll see in this table 1 here that these are mostly older patients over 65, but the hemodynamics were much better in the patients who actually got remimazolam. So in the remimazolam group, they were higher, statistically higher systolic blood pressures, mean arterial pressures in that group, and there was also a statistically lower incidence of phenylephrine boluses in the group that got remimazolam. So maybe remimazolam is something that in the future may be incorporated into clinical practice. Now, we talked about low-risk patients. Let's move beyond low-risk patients to intermediate and high-risk patients. In high-risk patients, these are patients who have postural symptoms. These are patients who have invasion of the heart and the great vessels. Preparation for mechanical circulatory support should begin before the procedure. There's actually fairly good data now that preparing for it and having some sort of preliminary access is superior to crashing onto ECMO or cardiopulmonary bypass. So in these patients, we recommend the placement of femoral, venous, or arterial sheets, plan for invasive monitoring, TEE, cerebral oximetry, and cannulate before you have cardiorespiratory collapse. There's little evidence from high-quality studies, but the consensus from the literature is that consider elective ECMO when one of the following is present: compression of more than 50% of the tracheal lumen, acute superior vena cava syndrome, compression of the great vessels, involvement of any of the cardiac chambers. There's an algorithm that has been published now, which is when you have these patients, you should have a primed ECMO circuit, you should have femoral access ready to go. Whether it is a failed intubation or peri-arrest, cannulation for ECMO should proceed immediately, even while the anesthesiologist is still focused on securing the airway and managing hemodynamics, and once cannulation happens, proceed with surgery. There are many possible approaches to cannulation. We can do the femoral, arterial, venous approach. Alternatively, there are some patients who are better candidates for internal jugular approach and the femoral return cannula. But the bottom line is, whichever approach you use, the perioperative management of these patients requires cerebral oximetry to ensure that there's good end organ perfusion. Management of a combination of one lung ventilation and ECMO ventilation, which means frequent arterial blood gases, to ensure that we're actually using a combination of lung protective ventilation. In fact, I'll take you back to our previous lecture where this is a case where you should use something called extreme lung protective ventilation, where you really eliminate the amount of mechanical power going to these lungs, let the ECMO do all the work. Crank the sweep up and minimize how much you ventilate these patients. Anticoagulation is important. In veno-arterial ECMO patients, you're going to have some sort of anticoagulation strategy depending on your institution. Manage bleeding, and distal limb ischemia is something that I think as a community of anesthesiologists, we don't think a lot about, but prolonged cases, we should think about that. And I'll kind of conclude by kind of giving you my algorithm for what kind of support to use. If the mass invades the heart or great vessels, consider cardiopulmonary bypass. If the mass compresses just the great vessels, think about VA ECMO. If the mass compresses the trachea, think about VV ECMO. And if VV ECMO doesn't work as well as you think it does, go to VA ECMO. And if VA ECMO is insufficient to support the circulation, then think about cardiopulmonary bypass. Thank you for listening, and thank all of you for inviting me here today.
Thank you to all of our speakers this morning. I will invite any of our audience members to come to the microphone with questions. While we're waiting for that, I would just like to ask with a show of hands, do you think that for your thoracic or lung surgery cases in your institution, are you placing mostly arterial lines? If yes, please go ahead and raise your hands. Good, excellent. Just want to drum up some discussion here. So it looks like maybe around a 50-50 in the room. Some persons looking like they're not placing as many arterial lines. And Dr. Chariku kind of brought up a lot of some of the parameters that we can get with non-invasive cardiac output monitors. So I wanted to maybe have a little bit of a discussion related to that. Are persons using non-invasive cardiac output monitors a lot? Show of hands if you're using NICOMs of any kind, the flow tracks, the cheetahs, anything like that. So not as many persons using that. So if I could, I invite Dr. Cherikou to talk to us a little bit again about, for example, the measures such as the PPV, SVV, and in the setting of these lower tidal volume strategies, how do we interpret some of those numbers?
Thank you. That's a very good question. First, in terms of placement of these monitors, I think there are always patient factors and procedural factors. Patient factors, I'm talking to an audience of anesthesiologists. You're very familiar with who needs an arterial line. Procedural factors really depend on how bad is the tumor, how bad is the cancer, how bad are the symptoms ahead of time. When you classify somebody as having intermediate symptoms, which means that they have symptoms with some sort of activity, even if not at rest, then you should consider placing some sort of invasive device. Now, in terms of how do you interpret pulse PPV and SVV, well, here's how you do it. Use a higher threshold than you would for other cases. That is the safe way to do it. Because what the evidence suggests is if you use just a 5% variation in stroke volume and you treat that, you end up doing harm to the patients because there's so many confounders in one lung ventilation. But if you use a very conservative threshold, like more than 10 to 15% variation in stroke volume, you end up with better success, you end up giving less fluids overall, and you have better outcomes. Thank you.
Hello. This is Nirvik from VCU, Richmond. So Dr. Cherikou, questions on the same lines. Thank you for the great talk. So you showed the algorithm, and about which you were talking just now. What are the chances, like it's a great algorithm to, I mean, we always talk about it to our residence fellows, but what are the chances in your experience that it will work all the time? Because, we are moving towards precision medicine, personalized medicines, things like that. So is it 100% it'll work? Probably not. What are the chances, 50%, 40%? Can you give a number on that?
Well, yes, I can actually, because the number I can give you is the area under the curve of these studies. The area under the curve of these studies is something like 0.82 to 0.88, which means it's going to work about 80% of the time if you use these very, very conservative algorithms. But again, I caution how you interpret these because these are typically both of these are single center studies, and they may not always apply to your population. So my approach is consider using them for high risk patients and make an algorithm that works for you, because that's actually personalizing. Care really means personalizing it to your population of patients, which may not be mine. It could be a different category of patients, different age groups, different kinds of pathologies. So I think that's the way to do it. Thank you.
Thank you.
Dr. Cherikou, I have another question for you. Sorry to keep you up there. My name's Ian. I'm from Dallas, actually. My question is mostly with hemodynamics and single lung, either ventilation or compromised ventilation pre-op, intraoperatively as well. My question is, you mentioned dobutamine, epi, norepi, vasopressin, all those to maintain hemodynamics in single lung ventilation. I guess my question is just to hear your thoughts on any other additional agents, such as like angiotensin II, whether, single lung ventilation, these patients might have a decreased in angiotensin II and disproportional Ang1 and 2, just because it's converted in the lungs. So I just want to hear your thoughts on that.
No, I think that's a great thought. And there's actually some very good evidence on angiotensin II and emerging evidence in cardiac surgery. And first, I'd say there's a big trial coming out in Europe called the Porthos trial, which is angiotensin II in cardiac surgical patients. I am eagerly awaiting that trial to kind of figure out what I do with it. But right now, there are maybe three groups of patients in whom I use angiotensin. The first, and I think the most obvious one, is as a fifth-line vasopressor when nothing else works, right? That's the most common one. So epi, norepi, dobutamine, vasopressin, and then after that, we use typically some sort of nitric oxide scavenger like methylene blue. If that doesn't work, then we use that. The second are the ACE inhibitor patients and the ARB patients these are patients who are chronically on these medications who may have some impairment of the renin-angiotensin system. Those are patients who may benefit from it. And third is the patients with kidney dysfunction. So again, this is data from cardiac surgery that we're really imposing onto thoracic surgery. And I don't think it's the same population of patients, but those are the patients in whom we would probably consider it. I'll tell you personally, even though I use a lot of angiotensin in cardiac surgery, I have never before used angiotensin on a thoracic surgical patient. But I think it's because the data is not there yet, and I'm just a data-driven guy.
Thank you all very much. We don't want to stand between you and the welcome reception. Thank you all for being such an engaged audience. Enjoy the rest of the meeting.